Hello, everyone. Welcome to a brand new session of our Facebook Live Chat with an Expert. We have been hosting these sessions on the third Tuesday of every month to discuss dementia-related topics that have been requested by caregivers. My name is Padma, and I'm a learning specialist with the Alzheimer's Society of Calgary. Today, I have great pleasure to introduce you to our presenter and speaker, Dr. Dawn Pearson, Clinical Associate Professor of Neurology. Dr. Pearson is very well known in dementia circles, and she currently works with the Alberta Neurologic Center. She has presented on several occasions in the past. She has done these Facebook chats with us, so she's a very familiar figure with our Facebook audience. And she's one of the highly rated neurologists in Alberta. I shouldn't forget to say that. The topic we have chosen for today is medical treatment of behavior changes in dementia, a very important and relevant topic for caregivers. We'll first watch a short PowerPoint presentation Dr. Pearson has very kindly developed for us, and then carry on with the discussion further. If you have any questions, we invite you to type in your questions in the comment section of this video, and we will address those questions at a later period of time. Because of some technical difficulties, I have not been able to present it simultaneously on our Facebook page. I do apologize for this inconvenience. So first of all, I would like to welcome Dr. Pearson to this chat. It's always great to have you with us. How are you doing today?
I'm very well. Thanks, Padma. It's good to see you again.
It's excellent. Yeah, you have been such a familiar face last year with our sessions, and you have never, you always accepted our request to come and present and talk to our caregivers, which is great. We really appreciate that. So we are ready for your presentation.
Yeah.
So
yes,
you can take it on from here.
All right. Thank you, Padma. And hello to everyone. Delayed greeting anyway. Today, I'd like to talk a little bit about behavior changes that are challenging. I'm going to limit this to Alzheimer's patients who develop behavior changes usually in later stages, moderate to severe stages, and what we can do about it. They are an equally difficult challenge for carers. Sometimes I think we as in the medical field underappreciate the challenge of just carers watching cognitive decline, as well as behaviors that they would never expect to see in their loved one. Next. So let's talk about what behaviors are people talking about, and is it separate from cognition? Probably not too separate. They do interconnect, but when in the medical field we're talking about behaviors, I'll elaborate on what we mean. So as you can see, a high percentage of patients with dementia do have behavioral disorders. And examples of that would be aggression or agitation, disinhibition, acting out in ways that you would never see your loved one doing socially, for example. These travel with cognitive decline. Some are triggered, and we will talk about some of the triggers. Some can be non-pharmacologically managed, and I hope to make a few suggestions that I've actually learned from patients and caregivers, not so much from the literature. So these behaviors, by people in the field, the medical field, they view them as mood-related and not particularly cognitive, not having to do with how you would how your memory is working, your short-term and long-term memory,
Mm-hmm.
how well your language is coming out. We're
Mm-hmm.
talking about more mood-related, anxiety-related changes. Next. So here, more specifically, what behaviors are we talking about? So the ones that I see the most are an anxiety and a panic and an anguish. I often use the word angst with my patients. And the truth of the matter is, I believe that angst is greater early in the disease because there is a sense, a very strong sense in the patient that something is wrong. They may not be able to articulate what it is, but they don't feel in control and they feel lost. And I think the angst and anguish is very great at that point. Of course, over time, their insight into their disease changes. And so the anguish part or anxiety part may or may not decrease. It may occur for different reasons later on.
Okay.
So hyperactivity is another, constantly moving, pacing, leaving the house seemingly for no real reason. Sometimes they are searching for someone or something, but sometimes there's no reason behind it, and it might be in the middle of the night. Irritability. Carers often tell me that at home it's like walking on eggshells. This is very, to me, that long term is very difficult and wearing on everybody, but particularly the carers, because you don't know what the day is going to be like.
Yes.
Some people can tell first thing in the morning by looking in their loved one's eyes whether it's going to be an on day or an off day.
Yes.
And an off day can be, an irritability day or quick to agitation day.
Yes.
I don't know that I can explain those necessarily, but I believe that each of you, any signs that you use to tell what kind of day it's going to be, I trust it completely. And it may be that that's your message, to have it a low-key day. Not a lot of plans, not a lot of busyness. Maybe that family Zoom call could wait another day because it's a bit overwhelming. And the last behavior listed here is disinhibition. So this is something very common early on in a different type of dementia, frontal dementia. This is more common later on in Alzheimer's, and this may be coming down the steps, a person, your loved one, coming down the steps in his or her underwear, not fully dressed, even though they feel that they're ready to go. They just lost the sequence. They started to get ready, and then they figure they're done, and there they come. They may say things that are much closer to the surface now. So if they don't like something, or they observe something like someone is overweight, they may just say that to them without hesitation. Next. So other behaviors that are common, but also I think very draining and straining to everyone, mostly the carer. So there are vocalizations. I've not met too many people in office, in clinic, who will do these things, but I have had several who, even during drawing a cube, for example, one of the patients continually whistled using her, like that kind of whistle, constantly throughout, and even in between our responses when we were conversing. Humming is another one, and they may never have been hummers before, but now, or calling out something over and over again.
Mm-hmm.
Sometimes it's a name, but sometimes it's the word help,
Mm-hmm. Yeah.
which is it's just difficult all around.
Mm-hmm.
And painful and hard to identify what is it that the need, what is the need?
Mm-hmm.
There may not be something that can be articulated.
Mm-hmm.
Then these are all things that are fairly active, but on the other side of the coin, there can be this profound apathy.
Mm-hmm.
So getting up in the morning, breakfast, sitting on the couch, TV on, that could be the day.
Mm-hmm.
And the truth of the matter is sometimes that's easier on carers than a lot of agitation, upset.
That's
I'm
right.
not promoting this in any way.
Yeah.
And we do know that people who are socially isolated, do not interact, are not active, actually decline faster.
Mm-hmm.
So it's not something I'm promoting, but
Mm-hmm.
it's just interesting from a carer perspective.
Mm-hmm.
So in addition to apathy, depression, and then the final one is the thing that it's a large part of my job to worry about.
Mm-hmm.
And it's sometimes I feel it's my job to just warn people that there can be changes that you just do not expect, and over and over again. And I'm very accepting of this. People will say, my Sally or my Jim would never do that.
Yeah.
And I totally understand where that is coming from. But the truth is they can and do because they're not themselves.
Right. Yeah.
So this can be verbal, physical, that causes just general wear and tear, besides physical harm, but just general mental wear and tear. The other part of this, of course, things trigger this, and one of them is having to shower or just bathe or get ready for an appointment or something like that. There can be so much negative opposition and yelling and maybe even physical resistance that it's hard to complete. I'll just comment here that I have told many a person to have home care come in for the shower, not to have it be the battle between the carer and the loved one. Sometimes I just think a stranger, it sometimes works better. Most of the time. Most of the time it works better. And you know, man or woman, male or female home care, this just has to be, or else they're set up for infection and all kinds of things. I'd rather minimize the situations that create resistance between carer and patient. Next. So why does this happen? I'll give you one explanation, which ties in with why there are medications that may help with behaviors. So we think that there is dysregulation in the neurotransmitters that are expressed particularly by the hypothalamus, the pituitary, and then the adrenal glands, which you'll recognize as producers of adrenaline. So that whole connector is called the stress axis, and it's highly activated in dementia, not necessarily because of the Alzheimer's changes, but because of the person's sense of loss and loss of control and anxiety, etc. This stress axis, which becomes dysregulated, often produces or overproduces dopamine, for example, which is a very activating neurotransmitter. On the other hand, it can also cause an imbalance or an excess of serotonin, which may have an opposite effect and be low, for example, in depression. So I've alluded many times already to the patient's awareness and sense of loss of control. This is something I feel is palpable in people early on. when I meet them. It's just, I cannot remove it. And it's profound and painful is how I see it. And it's hard to say to the patient why that's there. It often makes it worse when I try to explain a reason for this. So it's important to recognize, I guess is what I'm trying to say. Later stages of Alzheimer's, paranoia is common, and these are the two themes that come up over and over and over again. The loved one will accuse you of either taking all their money or cheating on them, or both. I won't say that there isn't other evidence of paranoia, like looking out the window, pulling all the drapes closed, practically before the sun is down, you know. There are other manifestations, but these two themes are very, very strong. And then why does this happen? So personal history is very interesting. For example, wartime experiences where we're still in that category of people who have served wartime. And we will be for some time, given the Afghanistan war as well. But I am thinking of a woman who participated in the Polish ghetto during World War II. And she recreated that scenario verbatim, word for word, every time I saw her for, gosh, maybe a year. Her husband and I had to kind of work to change the conversation or redirect, but it always came back to that time, which is it was not a positive memory really, and created some fear and anxiety, but those things can become relevant in terms of past activity. Some people say that getting older or having Alzheimer's, which are two different things, but some people equate them. Some people say that your whole personality traits, they just get exaggerated. I am not as convinced. I think that there are significant changes in some people, particularly in the domain of aggression, where there would have never been any evidence of that kind of loss of temper. So I'm not so sure I see that as much. Next. So it triggers that you can avoid is any situation that you can imagine that your loved one may feel overwhelmed, because what they bring out as a reaction to being overwhelmed is anger, angry outbursts. So if you're in a store and you go to the next aisle and your loved one loses sight of you, when you come back into view, there may be some yelling. There may be, where were you? Your loved one was, lost, feeling afraid, overwhelmed, even though you may have been out of sight for less than a few minutes. But that is the response to being overwhelmed and don't know what to do. It's anger. So sitting in the car, waiting for you to finish an errand, that's okay, probably okay if it's really quick, but sometimes the reason for sitting in the car is not always, it doesn't remain clear. So getting out of the car, walking down the street, looking for the spouse is not uncommon. Too much visual or auditory input. COVID has pretty much, eliminated these factors, but crowds, loud settings are often very difficult. And the response will be this anger, wanting to get out of there type of thing, even though the planning was to have a good time somewhere. Conversations with more than 4 people total can be overwhelming, just because following the conversation is a challenge. And people withdraw from conversation because they don't want to repeat themselves. Early on, they know there's some kind of problem because somebody somewhere has said to them, "I already told you that." It just is. It just happens, and this registers, and so that people withdraw more and may get angry. And then we love, really, the grandkids are great for people to see, but it has to be a limited visit. I have so many times heard that so-and-so will get grumpy with the grandkids after they're there for a couple hours. And overnights are difficult. I'd say, I don't know if there's an age cutoff, but you can figure it out. If they're under 5 and moving constantly, it doesn't sit well anymore. So these are just a few examples of triggers that lead to a person feeling overwhelmed, and then they will shut down, be angry, want to withdraw, want to get out of where they are. Next. So this is something that has come up repeatedly in my clinic, and I've observed it, but I just would like to, just as an aside, talk about how carers can also have a bad day. That is independent of the other person's bad day. You're allowed to have emotional changes and mood swings and things, but I say be very aware of triggers that come from history. Carers are often spouses, obviously. They're also often children. And there are dynamics. There is usually a very long history of, a marriage has dynamics, a family has dynamics, and people are closer or not closer to different children. Spouses are well aware of certain triggers, and by that I mean things that they used to say that would set the other person off. It's just, I want people to know that you yourself can reflect onto the patient your resentments even, or something that involved that person in the past. I think this is very difficult. This is human as well. I don't see this as a fault, but it's human. And if there is an awareness of that, of these holdover kind of resentments and things, try to keep them at bay. It's because that will reflect, and you will get back. Anger more often than not. I think the next slide has a quote from the Just Be Dementia Friendly. Now, I think this may, I want to make a point, but I also know that nothing is true every time. So the relationship does change if you are, argumentative. And I can give you an example, agitation. I had a mother and daughter here, and the mother is not driving. This is a big loss. And of course, she asks about when she will be getting her next car. And I think, at a point, you get tired of hearing that. And the tone in the daughter's voice and saying, you will never drive again. Why do you keep asking for a car? And I was the observer. I didn't jump in at that point, but you could just see, certainly feel and see the anger in the daughter. And then the patient was just beginning to ramp up. And, the daughter is the enemy for her.
Yes.
Now, it says if you're kind, patient, inclusive, you'll get love, laughter, and trust. I think that's a little rose-colored glasses in my opinion. Yeah. So, but it certainly makes a difference in the toll it takes on both of you. Mm-hmm. So there is some truth to this for sure. Mm-hmm. And another thing I've learned is, you know, if you are a child, if you were estranged from a parent, mm-hmm. I'm just not so sure that if someone calls you and says, oh, you should come back and take care, I'm just not sure that's the best situation. Mm-hmm. You can talk for days about obligation and blood relative and all that, but I am not one that feels that we should pretend everything was just great in the past and you come back. I think it's a setup for a terrible situation.
Right.
Okay. Mm-hmm. Next, so non-pharmacologically, so I've already alluded to, think about the events. COVID is doing that for us. But a lot of people are taking drives, stopping for ice cream when it's not busy or when it's not freezing cold. Keep it simple. It could be a drive in the car and then 1 cup of coffee at a drive-through, or ice cream at a drive-through, or something. But think about the events and be in circumstances where you don't have to correct all the time. Even in my clinic, of course, I don't see patients if they won't wear a mask right now. But of course, when they do, it slips down all the time, and the carer is forever walking over, pulling it up. But so that's in clinic. I would minimize, if you go to the park, go at a time when it's quite empty and you don't have to worry about that, and not so just minimize your need to correct or to say no. Think of a situation where, oh no, don't touch that. Remember, there's COVID or something. Just try to eliminate that. Yeah. All day plans are usually too much, unless you have a built-in break or a place where the person can just take a break and rest. But crowds and loud settings, which are not. And then I often talk about animals because I love them, and I believe that they can read people's emotional well-being very well, both dogs and cats. But for me to tell a carer to get a pet is just an added more task. That's right. So if there is a family member that is in your bubble that has a dog or cat, that the person knows if you can meet up, if you can bring that animal over, it usually is incredibly rewarding. And I will say that people who have gotten a pet, not on my recommendation, but have gotten, it's been incredible for the person with Alzheimer's. I have one person who, well, they may be listening, but I think it's just fantastic. He put together a chicken pen and has chickens. I mean, they don't sit in his lap and all that, but it's a very important part of his daily existence.
Right.
Anyway, next.
The robotic pets also could be equally comforting, right?
Yes. Just being out there, with him. Yeah. So, and non-pharmacologically, you've heard probably this too many times, but redirect. And some days that works really well. Some days it doesn't, depending on how embedded whatever it is the person is focused on. But this is a time when you can come up with anything out of the blue. So even if it's not quite mealtime, anything, could you set the table, anything that will occupy the person. I don't care if it's done right or not. As long as it's safe and nothing will get broken or require you to have to change or say no, then don't do it, but come up with something. We've also found that if you sit down with something, the person will join you. whether it's puzzle, drawing material, something, or you can encourage the person to come over, but anything to break the thread of what is upsetting. A walk or a ride in the car, going outside into the garden. And there may be triggers that are our trigger one day and not the next. I have an example of a person who is quite later in her stage of disease, and very unfortunately, her husband passed away with a heart attack. And of course, there's awareness of it and there's sadness, but she's not able to put it all together day to day. And her daughter is with her, very supportive family members. But last week, she took a photo of him and threw it on the ground. I think it was we interpret just the pain of having that there. It was not a good thing at that moment. And there is some evidence that she has wondered why he left her, that type of thing. So you just read the day. Read the day, and if just put the photo down or slip it in a drawer, or if you get any hint that is triggering high emotion. Same with car keys and the news on TV.
Great advice.
Not positive. And then this is something that I have not read anywhere, but I talk with people about honesty, delivering it calmly, because I think when people, yes, they have Alzheimer's, they have memory loss, they have cognitive problems, but I think that at some level, they know you, the carer, and they know when you're upset. And without yelling, without anything, I think that when they are saying very hurtful things, and we know that it can get right to the core, very hurtful, that you express to them, I am going to go to the other room, please don't come with me. I'm going to read, or you're saying hurtful things to me. I cannot have this conversation. If you are visiting your loved one, and of course, maybe they're still quite upset that they're there, or they blame you for everything, you can say, I'll have to come back another day. You're saying things to me that are mean. Spell it right out, but calmly, and get yourself out of the situation. I believe that's important, because I think it is on top of all of the pain of watching a person decline or not be the person that you married or lived with, is painful enough. And when this comes, I don't think that I'm not sure it's helpful to sit back and say, oh, he doesn't mean it, or she doesn't mean it. I think that you can call it what it is. Your emotion will be there strongly, in your voice, in your behavior. I think it's important to express that, and people respond.
Another great advice, I should say.
So this was about treatment, so I will non-pharmacologic interventions do not always work. The pharmacologic interventions, depending on who you read, have a slew of black box side effects. Yes, they do. I've listed them. But if I'm looking at side effects versus a person being able to be in the home, which is where the family would like the person to be, and there may be a need for medication. So you recall talking about the stress axis and the modulation of the neurotransmitters. Many of our medications that we use for behavior modification are targeted at those transmitters, neurotransmitters in the brain. So Dopamine is activating and can be a component of hallucinations, delusions, paranoia. And that's where risperidone comes in. I would say that's probably one of the most common first line therapies, can be very successful. It is a dopamine blocker, not total dopamine blocker, but it's specific dopamine receptors. But it can affect the heart rhythm. It can lengthen the time between two parts of the heart rhythm. It can lead, obviously, if you're blocking dopamine and you're on it for a while, it can cause something that looks a little like Parkinson's because you're blocking dopamine. So it usually is 8 to 12 months or longer on risperidone before that happens, but it can happen. It also can be sedating. It's not primarily a sedative, but a side effect can be that it's sedating. Next. So we think, so apathy and depression, just withdrawing, non-activity, is associated with decreased serotonin. So therefore, medications like escitalopram or fluoxetine, which prevent the serotonin from being taken up and recycled as quickly. It hangs around longer, so it has an effect longer. This has its own importance for depression that comes along with dementia. We always have to be sure we don't lose sight of the possibility of depression affecting cognition. In many cases, it's there. It's not the cause of everything. In some cases, we might treat the depression and the memory problem goes away. That is not as common. But even in a diagnosed dementia, the depression that is there can make the cognition worse. So we don't want to lose sight of that. And nausea is probably one of the biggest side effects with this, and hyponatremia or low sodium. Next. And of course, when there is low Gaba, another neurotransmitter, there is, you can have more anxiety, nervousness, panic, and therefore there are medications that promote Gaba. And these two examples here are the benzodiazepine class, lorazepam, which is Ativan, and diazepam, which is Valium. These I'm very hesitant about using. I have prescribed them when pre-COVID people were traveling and they were in a situation where they wanted to control anxiety fairly quickly in a specific situation. I have definitely prescribed lorazepam, say for a flight or something like that. But otherwise, although it can quiet the person down, it is meant to sedate, and therefore we know it's going to increase fall risk, and it's going to, in some ways, make processing and memory worse. So they're great for anxiety, but I worry when a person probably would need more monitoring because of that. Also, benzodiazepines are a sort of a stopgap measure. They're not meant to be something taken regularly every day. If you need something like that every day, you should probably look into something like escitalopram or fluoxetine to help manage it better on a chronic basis. And that's what I have for you.
Thank you very much. That's very, very informative presentation, I should say. Really, really informative. So do you have some time for questions, Dr. Pearson?
Absolutely.
Okay. So I do have a few questions that That I think it's great if we can discuss that. So you did allude to the indications for using medications in your presentation. You
Yes.
did mention that. That's already been answered. So I'll move on to the next question. So are there any behaviors that do not respond to medications?
So there is always the chance that a person will need more medication than we could recommend because of concern over negative side effects. And yes, there are. Either it's a degree of behavior that we cannot fully manage, or behaviors continue, and that is difficult. That's when I do recommend that at least the transition team needs to be involved, because I don't know where we're going, and I am I don't want the home situation to have a crisis where the person falls and breaks a hip or has bleeding in the brain or anything like that. Because again, it's strain and stress on the family that they didn't watch, or I don't want to add that burden.
Right. That's where you suggested bringing in home care for bathing
and home care may be there, but specifically the transition team and have that conversation, because I can't see. I will be honest. I tell people if I can't see it working at home.
Great. Is there a specific sequence for prescribing these medications for managing behaviors? Like, how do you start with an antidepressant and then move on, or is there something like could you please explain that?
That's generally true. I would say that earlier in the course, something like escitalopram is started for a lot of reasons: depression, sadness, withdrawal. Yes. So in a way, even though it's not a scripted timeline, that tends to be how it works. It's only moderate to later stage that any type of an antipsychotic or dopamine blocker would come into the discussion.
So how long can a person be on these antipsychotics without having major side effects?
Right. Well, it may not be time dependent. Some people could have a cardiac rhythm change, right away. We don't know. We often recommend an ECG before starting the medication, but even then, we cannot predict necessarily who will have it. The reality is that when people are talking with me about this, the behaviors are ongoing, right? They're living with these behaviors. Someone may be at risk.
It's true.
So not many, but a good part of the time, I will be perfectly honest, a person, the carer will say, I don't know that I can wait for an ECG, which I understand. I understand because I don't have the equipment for doing that. I couldn't read it anyway. Getting to the family doctor to have this happen could be several weeks away.
That's true.
So that's the reality of when the conversation comes up. If there's any cardiac history, I probably would not start the medications, and we would try all of the non-pharmacologic modifications, and once again involve a transition team.
Right. Yeah. Great. So what side effects should caregivers watch out for if their loved one is on an antipsychotic? Too sedated probably means too high of a dose, because they're meant to, their job is to try to calm down the paranoia, calm down aggression.
but not put a person in bed.
Right.
So if they're barely cognizant, they're oversedated, the dose is too high, and we could lessen that. So
fall risk, maybe risk of fall.
That's right. So in particular, the benzodiazepines, but all of them, any change in sedation increases the fall risk.
Yeah.
Yes. And if someone is very unsteady, I may not start the medications, or I may be very, very hesitant, or I may do it as a stopgap measure until they can decide on what next steps are.
Right.
So it is a big decision. Other side effects would be would be any type of sometimes gait change. They become shuffling, which happens with antipsychotics with the dopamine blockade. Oftentimes my patients are not on those meds long enough to develop that, because when they're started, they're later in the course anyway, and may not be on it for a long time.
Do you think cannabinoids can be a safer alternative to antipsychotics?
I think that's a really good thing to bring up, because I have okayed that several times, and I will say that right now, in my cadre of patients, I have more people with frontal dementia on cannabis or CBD oil is what they're using, the only medication. And it's the only thing that has, in one case, has allowed this person who's, in his late 50s to be at home with his wife and 2 sons.
But you wouldn't suggest using the marijuana plant or things like that, but it's the oil or the synthetic that you would prefer?
It's almost always oil, just because I don't want any smoking, but sometimes it's also baked in the
edibles
or lozenges, because that's it doesn't generate another possible resistance, or it's goes along.
So can someone who is being treated with antipsychotics, can they be weaned off? If it's been prescribed for a short period of time, and when things settle down, could you wean off that person to a safer medication?
It is definitely possible to wean. I'd say that the chance of the behaviors being gone or having settled is not a great, there's not a good chance. You just have to be aware. I am all in favor of getting rid of any medication that is not benefiting or isn't needed anymore. So I'm very happy to try that, but I would be conservatively, and I would tell them, these are the behaviors, we would like them to be controlled. If they're not, go right back.
Right. Okay, so we have taken some more extra time, 10 more minutes. But I just wanted to make sure that we, we get these questions, we address these questions, because these are questions that caregivers would have in their mind. And I wanted to be able to have the opportunity to raise them with you and have them answered by an expert like you. So thank you so much. This has been a very informative presentation. And I would like to express our deep gratitude to you for sharing your precious time and knowledge with us. And, again, I have to say that you have been such a great resource for us, for our caregivers during this pandemic. There is no doubt about that. And here is a very big thank you from all of us, our entire team at the Alzheimer's Society of Calgary. And as always, this has been a great pleasure to chat with you today.
I'm happy to be here.
Yeah, thank you so much. Thank you so much. And, I'm hoping to post this video on our Facebook page. And what if someone add some questions in the chat box? Would it be possible? Would it be okay if I can send them to you if I'm not able to answer them on my own?
Sure.
Would you be willing to
Absolutely. No
help
problem.
us out with that? Okay, because this is such a relevant topic, and caregivers always have lots of questions about medication. Yes. And it's not easy to have an expert like you available, right? Especially in these COVID circumstances. Yes. So we really, really appreciate you for joining us today and for accepting my invitation, my request every time. It's always a great pleasure to chat with you today. So have a great day, rest of the day.
You
we'll
too.
See you before the next chat. Yeah?
Bye-bye.
Bye. Have a great day. Bye.